Hello, everyone. I'm American College of Radiology Director of Public Affairs, Sean Farley. Welcome to the PAMA AUC Ready webinar. We'll have 3 presentations tonight, followed by a question and answer session. First, ACR Economics Commission Chair Dr. Ezekiel Silva will explain current CDS requirements. Next up, Dr. Asha Malal will explain how Mainline Health of Pennsylvania used the Radiology Support, Communication, and Alignment Network, or RSCAN, to introduce referring physicians to AUC and implement CDS. Then patient advocate David Andrews will explain how implementing CDS can strengthen patient trust and patient-centered care. After those presentations, we'll be joined during the Q&A session by Bob Cook, Vice President of the National Decision Support Company, which offers the Care Select Imaging ACR Select CDS platform. But before we get started, I'd like to go over a few items so you know how to participate in tonight's event. By default, you join the presentation using your computer speaker system to listen to the presenters. If you would prefer to join over the telephone, just select Telephone in the audio pane, and the dial-in information will be displayed. You will also have the opportunity to submit text questions to tonight's presenters by typing your questions into the Questions pane of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the Q&A session. Also, tonight's webinar is being recorded, and you will receive a follow-up email within a few days with a link to view the recording. So with that, I would like to now introduce ACR Economics Commission Chair, Dr. Ezekiel Silva.
Sean, thank you. This is Zeke Silva. As Sean mentioned, I chair the ACR's Commission on Economics, and we're going to walk through where we are here at the end of 2018 as we prepare for the start of 2019. But I think to really understand where we are today with the program, I'd like to walk us through a timeline by going back in time. And let's go back in time about 18 years. Next slide, please. What we saw in the early 2000s was the utilization of imaging services growing and accelerating. And why that was significant was that it was gaining the attention of policymakers. In 2005, the Deficit Reduction Act was passed. It was one of the first significant reductions to payments for radiology services. Over the next few years, we saw plus or minus around 13 different payment reductions. Much of that was focused on the technical component of what we do, but not all. There were some reductions on the professional component side as well. In an attempt to control growing utilization, we saw increased focus on a couple of programs. Number one was pre-authorization. We saw that coming more and more from private payers, but we also saw some focus on pre-authorization coming from government payers. For example, in President Obama's 2010 budget, there was mention and recommendation to establish a pre-authorization program for the Medicare program itself. Against this, and I will add also, there were other focus from other specialties, for example, Choosing Wisely, where we had other medical specialties proposing solutions for appropriate utilization of imaging. So put us in an interesting position, a challenging position, where we were sort of forced to develop a solution. Next slide, please. As we pondered different solutions, certainly one was inaction, just accept that more payment reductions could occur. We could also have just accepted that pre-authorization was inevitable, or we could have been more proactive. And what we did is we knew we had a program that was approximately 25 years old, and that was the appropriate use criteria. These were imaging-specific guidelines. They were evidence-based. They'd stood the test of time. And we made the decision that consultation by ordering physicians had the potential to eliminate unnecessary imaging. Next slide, please. Independent of payment policy, let's just talk about some goals of any imaging AUC policy. Understanding that we're in the midst of a shift from payment policy from value-based care or volume-based care to value-based care. So any AUC program, again, regardless of payment implications, has the potential to contribute to value-based care. I've already mentioned it's evidence-based, protects patients from unnecessary procedures and potentially unnecessary radiation, and it also promotes care coordination. Next slide, please. So as we look at policy fundamentals, so now we take those basic benefits of AUC in general, and now we start to convert those into some actionable policy. These are some policy and fundamentals early in the development of the program. Number one is we would require a consult, but not necessarily a hard stop, not necessarily mandated adherence to imaging AUC. The program would apply to advanced diagnostic imaging services, would be an alternative to prior authorization that the rendering physician, or the furnishing provider as it's sometimes called, would bear all financial risk from a technical and professional component side. Those that develop AUC would be qualified provider-led entities and fulfill the criteria to be assigned that nomenclature. And there would be electronic clinical decision support mechanisms which could seamlessly integrate into electronic order entry. There would be a mandate for outliers, or identification of outliers, physicians not adhering to the AUC criteria, which would later be subject, based on 8 priority clinical areas, to prior authorization. Next slide, please. As the policy evolved, the more specific rules from the program became more apparent. Specifically, ordering professionals would consult AUC. Again, that would be integrated into an EHR, and importantly, there would be at least one qualified CDS mechanism offered at as a no-cost free option. The ACR anticipated G-codes and modifiers would be necessary for or required for that consultation. We'll talk shortly about where we are in that part of the process as 2019 approaches. We know there would be exemptions, particularly inpatient services and ER or in teleservices, exemptions for those lacking internet connectivity, and others as they evolve and as necessary. There'd be an educational component, that the tool would provide immediate feedback to ordering professionals on the appropriateness of the studies they're ordering, and that there would be multiple qualified clinical decision support mechanisms identified and capable of fulfilling the criteria which I've described. Next slide, please. I'd like to visit the original timeline. The original statutory language was part of a law called PAMA of 2014. It started affecting payment policy in 2015. The statute itself, as originally drafted, had the following, what I sort of consider 4 important decision points or chronological events. Number 1, in November 2015, the specific AUC criteria would be identified. By April of 2016, a list of qualified clinical decision support mechanisms would be published. And by January 1st, 2017, the consultation would be required. That would essentially was intended to be the go-live date, where payment was at risk and the program was fully implemented. And then by 2020, the outliers would be identified. We're going to visit or revisit shortly the timeline as we stand today. But understand that when this program was created and when this timeline was initially described, the ACR fully believed, and we still believe to this day, that we had a solution ready for implementation. In other words, we didn't support this timeline under any other guise except for the fact that we thought it was ready. Next slide, please. So let's fast forward now to the Medicare Physician Fee Schedule rulemaking process. What I'm going to describe now are proposed rule language that was released around July 1st of this year. These are proposals which will go into effect for the 2019 Physician Fee Schedule effective January 1st of next year. Because they're proposed, they are subject to public comment through a rulemaking process. Those comments have been submitted. The ACR, and I'm going to go through some of our comments shortly, but the ACR submitted lengthy comments regarding the program. We'll find out the final rule probably around November 1st. And that rule will affect, again, payments 8 weeks later on January 1st. So let's go in some detail what was in the proposed rule. And this is sort of the latest information to provide. Number 1, the applicable payment settings. They expanded it to not only include ER, physician office, and hospital outpatient, but also independent diagnostic testing facilities. The ACR supported this. There's language regarding the consultation. So when we talk about consultation, we have ordering professionals. Think of those as our referring docs. And then we have furnishing professionals, which are many of the individuals on this call tonight. The consultation, or the language in the proposed rule, stated that the consultation may be performed by, quote, auxiliary personnel incident to the ordering physician. The ACR's comment was that we thought this needed to be more specific, not just auxiliary personnel, but clinical staff. Imagine a nurse practitioner or a registered nurse or a medical assistant, that we thought those individuals needed to have greater clinical credentials than simply an auxiliary personnel. We've made that comment. We're waiting to hear what's said in the final rule. Reporting of claims. There's language in there. Recall that a couple of years ago there was language regarding G-codes and modifiers. Well, that's resurfaced, and that is, in the ACR's perspective, a temporary solution. It's our ability to get the program sort of off the ground, if you will. We've advocated for a long time for a unique consultation identifier. So we, at some level, are a bit disappointed by this proposal, but we certainly understand why, from a claims processing perspective at almost a national level, why this change was necessary, proposal is necessary. Next slide, please. I've already mentioned briefly some of the hardship exemptions. Well, going into 2019, those rules have been made somewhat more specific. Insufficient internet access, EHR, or clinical decision support mechanism of vendor issues or challenges, and then extreme and uncontrollable circumstances. This hardship exemption is a self-attestation. There's no documentation that needs to be provided to the government or CMS, but they do state that they would like documentation locally to be maintained. Those of us that discuss the macro program or the quality payment program, remember there are certain exemptions in that program for promoting interoperability, or what was previously referred to as meaningful use or advancing care information. The exemptions for the AUC program are distinct from those. While there may be some overlap, they are separate exemptions for the hardships were described. And in general, the ACR supported this concept. We understand that hardships are necessary, and we generally made supportive comments. The outlier timeline, which I mentioned earlier was originally 2020, has now been pushed back to 2022 or 2023 by necessity. The ACR understands that requirement. And then lastly, the final rule, as I mentioned, is expected around November 1st of, and that should actually say 2018, but it'll be for the 2019 fee schedule. Next slide, please. So let's bring this all together. I'm going to close with my last couple of slides. This is the current timeline as we speak today. We're between those first two green dots. We're in September of 2018, somewhere in between there. We are currently actually in a voluntary reporting period. So practices and facilities that are engaged in clinical decision support already have the ability to voluntarily report. And the ACR actually supports that. It's a claims-based process. It's a modifier, QQ, and it's appended to the CPT codes themselves. Starting in January of 2020, based again on the proposed rule, will be an educational and operations testing period. At that point, the clinical decision support process is expected to be in place, and those, what I've currently described as G codes and modifiers, or whatever the claims processing is and recommendations are at that point, it is expected that those will be reported. Now, I will say, we've asked the question at CMS, we understand that if that claims process is initiated and inaccurate, the payment will still occur. But the question we've asked CMS is, what if there's no attempt made at all? And as soon as we have that guidance from CMS, we'll provide it to our members. January 1st, 2021 is the start date. That is when it will go live, that is when payment at risk, and that is the timeline for full implementation. And I've already mentioned the outliers will approach in 2023 or 2024. Next slide, please. So with that introduction, I think we're there. You know, I mentioned that 2017 was the start date. Well, because of the delays I've described, we're actually 6 years into knowledge that the program is forthcoming. At the same time as the program has evolved, there's AUC and CDSMs in multiple sites, 500 health systems, 2,000 acute care facilities in all 50 states, and I can tell you those numbers are growing. And as I mentioned earlier, it's available via a free web portal. Next slide, please. I did mention the quality payment program. For referring physicians or ordering professionals, there's the ability to gain credit within the merit-based incentive payment system for the improvement activities performance category. So those physicians that are using these products and are using this program during their ordering, they actually can receive a high-level MIS improvement activity credit, which is pretty significant for overall scoring within the program. Next slide, please. This is my last slide. And I just want to restate this point that we talk about this program and we talk about the fundamentals of this program, and we talk about why this is the proper thing to do, that appropriate utilization, care coordination, controlling radiation. And I think, and you're going to hear later in this talk, above all, patients having confidence in the studies that are being ordered for their respective conditions. And all of that makes this absolutely the right thing to do. But I think it's fair to acknowledge that there is an alternative that we may or may not like, or I don't think we'll like, and that's prior authorization. That's not what we're talking about. This is point of care We're not asking for staff to sit on the telephone for pre-authorization. It is consultation, not necessarily adherence. So there's not a hard stop. And above all, it's intended to be an educational tool for physicians and patients based on evidence on a system that's 25 years old. With that said, I want to thank everyone for their time. I want to thank you for your patience with my somewhat scratchy voice. And Sean, I'm going to turn the program back over to you. Thank you.
All right, Dr. Silva, thank you very much. Now I would like to introduce our next presenter, Dr. Ashima Lal.
Thank you, Sean, for the introduction. I guess we can go to the next slide. The topics we'll cover today is using RScan to introduce the ACR appropriateness criteria and clinical decision support, radiologists' role in CDS implementation, and some of the helpful ACR resources which are available to all of us. We can go to the next slide. Just a little bit about the setting in our hospital and our group. I'm one of the members of a medium-sized private practice group, Radiology Associates of the Mainline. We have 46 radiologists and physician assistants. Mainline Health is a nonprofit health system serving western suburbs of Philadelphia. We have 4 acute care hospitals, Bryn Mawr, Lankenau Medical Center, Paoli, and Riddle, and we also serve many outpatient centers. We can go to the next slide. So just starting CDS implementation with RScan, I'm sure many of us already know about RScan, Radiology Support Communication Network. Just briefly, it's actually a quality improvement initiative that incorporates the appropriateness criteria we're talking about and provides access to the portal version of Care Select. Again, we'll talk more about it. It's a collaboration between the radiologist and our referring physicians. And the goal is to improve the ordering of the high-value imaging exams, which ultimately benefit our patients. And lastly, it is funded by CMS to provide medical practices the support to move into future value-based payment models. Now, everybody would ask, why did I champion for RScan participation? It's, I guess, the right thing to do and smart thing to do. And the reason I thought it is, I think it's important is because we've been having CDS conversation for many years, and this was the best way to really test firsthand what the roadblocks would be, how success would look like, and it was actually freely available. We could use a web-based portal on the side and participate and actually know it by ourselves how this success would look like for us. And that was one of the main reasons I thought this was one of the best projects to be tested. And there were some other tangible benefits that led to our participation. As you all know, and Dr. Silva just said, this applies to our improvement activities. You can get credit for MIPS and MACRA. It actually positions us well for value-based models and our role as leaders in that, and also introduces us to appropriateness criteria in real life. So I think this was an absolutely right choice for us to participate in RScan. Next slide. Now, the next thing was we had to collaborate with our referring physicians. And why did we engage our ED physicians? We actually leveraged our strength. We had great relationship with our ED physicians, and we thought that would be the great group of, colleagues to test this RScan project with. So we had meetings with the chairs and system chairs of the ED department and chiefs, and we articulated what our purpose would be, and we had a great luck in finding the right champion, and that was Dr. Pasden, who could articulate the purpose to their team very well. Like we had incentives for radiology, we had incentives for ED as well. They could use this RScan successful project for their improvement activities, and they are going to be also using appropriateness criteria and CDS in the future years. So this was a great opportunity for them. And as you can see, Dr. Rebecca Pasden's code, she said this was by participating in choosing wisely, she really did feel like this was a great conversation between specialists, primary care, and our ER physicians. Next slide. Now, a little bit details about our Mainline Health RScan project. We actually retrospectively looked at 84 baseline cases for pulmonary emboli, but just to be clear, for RScan, you only need 25. We just went a little bit beyond because we wanted to really see the trend. And once we looked at the retrospective, cases, we actually shared the results with our ED champion, Dr. Pasden, and planned the educational intervention based on the results. And we carried out the educational intervention. A little note there, we wanted the patients to be included in decision making because we hear so much that patients should be engaged. And we just thought we have a great RScan platform. We already have so much work done. If we include patients in this platform, this would be great to see what really patients want to know about appropriateness criteria. This would actually prevent rework, and we have already choosing wisely patient-friendly material that we could share with the patients, and we had our administration and our ED physicians on board with that idea. So our ED physician shared patient-friendly material with the patients while they carried the process improvement for the CTPE. Thereafter, we collected 90 post-education cases. Again, you can complete the ORSCAN project with 25. We just chose to do more just to understand the trends. Can we go to the next slide? Now, briefly, the results. Our collaboration achieved 45% improvement, but I would tell you, the reason I think we got 45%, we actually chose the right project because we have to know where there's chances of improvement. That's the first thing. We have great collaboration. We had a great champion from ED. So those were all very critical factors for getting the collaboration. And on top of it, we had a great platform and it was easy to use. Now, patients, since we added this patient component, and you're going to hear a lot more from Danielle, David, the patient perspective, patients really liked that we shared, the material with them, and that was communicated to us by the ED physician and also through our surveys. They wanted this to be used for other projects. They found the Choosing Wisely material very high quality. And as a result, we presented at the CMS National Quality Conference, and it was received well by them. And our plan is to work with the mainline health stakeholders who helped with this project and the ACR team to develop a toolkit that's available for all our scan projects, hopefully in the near future, and should be available to all of you if you wanted to use for your RScan projects in the future. Again, as you see, the relationship with the referring physicians has strengthened, and it gives us idea how to use decision support. And as you can see on the right-hand side, Dr. Pasden, she shared with us, when patients understand what's happening, they are more actively engaged and empowered. And this was her quote. She said, once they saw that they had something to look at and hold on to, the patient choosing wisely material, it really solidified their whole meaning of appropriateness, because ED physicians usually talk, but patients forget. So this had some real value for the patients, and we'll hear more from David in the next talk. Can we go to the next slide? Now, a little bit briefly about the case data. I'm sure you're going to get this slides afterwards. We had 84 cases post-education, 90 cases. Again, the minimum is 25. And you can see how the green increased after education and intervention. And you can see our average exam value rating was 4.9, on the lower side. And the higher the number, that's after average, after the education, it was 7.13. The higher the number, the better. So you can actually see the results here, and hopefully you'll get the slides later to look into details. Next slide. How RScan will help support CDS implementation, and we all know, like Dr. Silva shared with us, it's coming soon. This can help us buy, our buy-in from executives for radiology leadership. We can really understand. We have actionable results. We have meaningful data to share. It's one thing when we share the general articles and stuff with the executives, but when you've tested in your own organization and gone through the whole process and showing results, it does have a different meaning. So I do think this is very helpful to show results to your executives, and it'll help get the buy-in and a seat on the table. And again, it reinforces our role in collaborative leadership models, because we are not alone. We work with our referring physicians as leaders. We can go to the next slide. So now next steps, what do we do after this? How to begin the conversation? And I'm sure all the people here, all the audience, like we come from different practices where we're in different stages of CDS implementation. Some of them are looking at vendors. Some of them have already signed up. Some of them are already implementing, while others are looking at workflow. But there's one thing we all can do. We can share the ACR resources, the material with our executives. We have a lot of radiologists in multiple committees, operation, executives. We can share them, share the materials with our referring physician, the medical staff leadership through the newsletter. So we can all do something and start the conversation based on the stage we are in the implementation process. And we also, how radiology should be involved. But why we should be involved, I'm sure you all will agree that radiologists know best about the appropriateness criteria, because we all get consulted every day as to what is the best study. So it is very important we are on the table making these decisions. Now, the other thing we can all do is plan CDS RScan projects, whichever stage we are in implementation, because it is a free web portal available. Even if we haven't signed the vendor, even if we don't have a plan, live date at this point. So once you have the RScan project, it doesn't take that long. We did like 90 cases, but you could do with 25, 30, 40 cases and actually show results to the executives and start the conversation. It is much better when you have the data from your own institution. And I would say that RScan is very scalable. Once you've done it in one setting at a smaller scale, you can roll it out across the health system, customize it. Like we added the patient engagement. I'm hoping somebody will add another component with patient involvement, and we can, I'm sure our RScan leadership will be happy to scale it if it is something that's received well by our community. Next slide. How RScan can help post-implementation? It has all the, we can all work with our ordering physicians and look at what is most important to us. What is important to our health system may not be important to the other health system, but there's a list of projects, and the RScan team is adding more projects as we go, so we can use what suits our health system, and then it can become a part of educational and quality process. Again, the most important thing is the hospitals are talking about utilization management. This is a great example where we can actually participate and be part of that utilization team for the hospital, and this is going to be the future. So I think this is a great way to be part of the leadership, and I think it will continue to help us build relationship with our referrers as we did at Mainline Health. Next slide. Again, this is last but not the least, a lot of resources that are available at the ACR. We can start. There's material for referring physicians if you want to share, which we shared with our ED physicians. There's an RScan site with the complete list of RScan projects and step-by-step guide. And again, as I said, the toolkit for patient involvement for all the projects or most of the projects should be coming soon. And there are multiple case studies that you can look at and see and customize to your health system. Thank you, everybody. Thank you, everybody, and I'll look forward to your question and answer.
All right, Dr. Lal, thank you very much. Now it's time to introduce our final presenter tonight, patient advocate David Andrews.
Thank you, Sean. Next slide, please. You might be wondering, what's a patient doing here? I make no claim to any particular radiological expertise, but I've had a lot of exposure to imaging of various sorts. And I was asked by Dr. Rawson, who some of you may know, to become a part of the Patient Family Centered Care Commission, the outreach portion of that, of the ACR. And through that, I was then asked to become a part of the ACR Appropriateness Criteria Committee. So I am the patient on that committee. And the fact that the ACR wanted to have a patient in that position is a strong indication that the patient perspective on imaging is an important part of this process. A patient subcommittee was created. The group has started to make patient summaries of the the appropriateness criteria that can be in a language that's accessible to patients, so they get better educated about imaging options and can participate better in conversation with their physicians about appropriate imaging. We can give you a story, which is a personal experience that illustrates a bit of a point that Dr. Silva made about the recommendations being something that one consults, but you're not necessarily required to adhere to it. I had, a few years ago, I was sitting at my desk and started to have a rather uncomfortable pain in my side. I tend to have a very high pain tolerance, so I usually, when things like that happen, I just figure, okay, I'll sit here a while, take a few deep breaths, and this will be fine. It was going on longer than that. My wife happened to come in and she saw me sitting there looking very white and sweating. And so she said, as any good wife might say, we're going to the emergency department. So I said, yes, dear, and off we went to the emergency department. They talked to me. They decided that I probably had gallstones, and the appropriate thing that one did with gallstones was to give you some pain medicine, send you home, and say, you know, if it doesn't go away a while, get in touch again. Except that two things were important that we both recognized, my wife and I. One was that I had a temperature, and I rarely, if ever, have a temperature under any circumstance. And two, that my wife knows that I have an extremely high pain tolerance. I was literally giving a talk once and passed a kidney stone and went right on talking. So that gives you some idea. So she said, no, there's something really wrong here, and you need to do something to make sure that we know what the problem is and we can get it solved. So after some lengthy and somewhat tense conversations with the emergency department physicians, we convinced them that they should do an ultrasound. They did. They discovered that I had a rather badly misshapen gallbladder with a lot of stones in it, and that plus the temperature led them to conclude it's time to have an emergency surgery to get that out. As it turned out, the surgeon who did the surgery said it was the worst gallbladder he'd ever seen, and that it was actually quite close to bursting and potentially creating other problems. So here's a case where I think the emergency department physicians did exactly what was appropriate to do, but knowledge that my wife and I had about myself led them to perform another test, an ultrasound in that case, which identified a problem that then was dealt with, I think, rather appropriately. I think this kind of thing happens more often than we may think it happens, but the patients are an important part of the conversation. And it's also the case that patients now don't come as some kind of blank slates. Patients know about MRIs and CTs, and they know about ultrasound, and they come in and think they ought to be getting something or other. So the conversation between the patient and the referring physician and the radiologist is an important one. Next slide, please. So in my view, there are three players involved in any imaging decision. This is sort of independent from my point of view of the funding and those issues that are probably of greater concern to many of you that are listening. I mean, there's certainly a referring physician. Referring physicians may or may not be all that familiar with the appropriate use criteria, but now with the clinical decision support, they can have at their fingertips those criteria that they can rely on. The radiologist obviously has been involved with the creation of those criteria, but also is available for consultation about what might be appropriate in a particular case. But as my story, I hope, illustrated, patients are someone who ought to be involved in this conversation as well, not just for purposes of making the right decision, although often the case that patients will have personal reasons that they don't want something or that they think something is more appropriate that needs to be engaged in conversation with the referring physician, or in a rare occasion when a patient gets to talk to a radiologist. But patients do come in with prior conceptions. The sort of standard example is the patient who has a lower back pain and says to the doctor, I need an MRI. And in fact, MRIs are not necessarily appropriate unless there's some other conditions that suggest it ought to be. So it's important to keep in mind that the clinical decision really is among three people rather than just a conversation between two. Next slide, please. So you know about prior authorization. We patients are not normally engaged in it, although interestingly, I've had a few cases where prior authorization was refused, and as a patient, I had to get involved in the conversation. But that's not the normal state of affairs. On the other hand, I've certainly had situations where prior authorization delayed an imaging study that was an appropriate one, but it took a while to get around to having the prior authorization for it happen. I've heard a lot of stories about the burdens that prior authorization creates. So by having a clinical decision support process, the consultation with that becomes something which under most circumstances may eliminate the necessity for a complex or protracted prior authorization process. To the extent that these are integrated in the electronic health record, which they are fairly widely and will be more extensively as time goes on, and you'll probably hear some more about that later, this becomes a fairly easy process for the physician to consult this, and the consultation becomes a means by which, in most cases, prior authorization is not necessary. So time gets saved, the imaging gets done faster, the doctor doesn't have the same amount of demands for doing the prior authorization, and furthermore, by having this information available on the computer, there's an opportunity for the physician and the patient to share the information together and have a conversation that helps the patient better understand what's happening and why it's happening, so that everybody's on the same page. The patient doesn't walk away thinking, well, I should have had an MRI, but they wouldn't have let me. You can present them the information to suggest why an MRI may not be appropriate in a particular case. And everybody then is working together in what I referred to as the triangle earlier. Next slide, please. So my call to action, if you will, is that I think it's really important that as with any implementation of something new, it takes some time. People need to learn how to use it. So it's important that people learn about the clinical decision supports, become familiar with them, and how they're used. Learn how to use them effectively. I had a demonstration, and for one who knows how to use it, it's easy, it's quick, it's slick, and it's very, very informative. Integrating it into the workflow, and I would say in particular, integrating it into the workflow as a part of something that can be shared with the patient to make sure that the patient understands what's happening and why. And finally, I hearken back to the notion that doctor actually comes from the same root as a word for teacher. And I think this becomes an important opportunity for physicians to engage in a little more education of patients, so that patients are more familiar with really appropriate imaging and not just what their friends and neighbors have told them or they've heard about previously. Next slide, please. That's all for me. Thank you. And back to you, Sean.
All right. Thank you very much, Mr. Andrews and Drs. Lal and Silva. And now Bob Cook, Vice President of the National Decision Support Company, will join us as we begin the Q&A session. Now, as a reminder, you can still submit questions to the questions panel in your attendee control panel. And with that, we'll get right to our first question. This one is from Vicky Parikh. That is for Dr. Silva. Do the hardship exemptions apply to referring physicians? And if so, would we know which referring offices have a hardship exemption and which will not?
Yeah, thanks, Sean. And this is an important question. The hardship exemptions apply to the ordering professional, the referring physician. It's their responsibility to communicate to us, the furnishing physicians, that that exemption is in place. Now, recall I said earlier, that's a self-attestation. So that office merely has to make that self-attestation if that were questioned at a later time. So the important question that we might want to ask is it the responsibility of the furnishing provider to confirm or validate that? And the answer to that is we think no, but we've gone very specifically, we've asked CMS that question. We've said in this scenario where we understand there's a hardship exemption from one of our referring physicians, we communicate that to CMS, and we think that's going to be in the form of a modifier. We're sort of waiting for that claims guidance, and as soon as we have it, we'll communicate that to our membership and to other professionals. But that's an important question. We shouldn't have our payments put at risk if that exemption proves to not be accurate. And I don't know, Bob, do you have anything, Bob, cooked out on that? Did that summarize our position?
Yeah, hi, Zeke. Yeah. I agree with you completely. It is a self-attestation, and similarly, the modifier that gets submitted, on the claim is also, an attestation to the furnishing provider that you're aware of the result of the consultation, and that's all you're really attesting to here. And so, with respect to that exemption on the hardship side, or even adherence to AUC for that matter, it is not incumbent upon the furnishing site to necessarily verify that that has occurred. There may be other reasons to do that, but certainly not in the context of regulation.
Great, thank you, both of you. This next question is from Munib Sana. It is for, well, we'll go with Bob Cook. Are there strict guidelines for becoming a QCDSM? Does CMS list them somewhere, and how does one get approved and or apply?
Yes, so clinical decision support mechanisms are qualified by CMS. CDSM producers apply to CMS, and then the application is reviewed, and CMS issues a qualification accordingly. The listing of both CDSM requirement and qualification requirements, as well as approved mechanisms, are on a website maintained by CMS called Imaging AUC, and I will place the link in the chat box. That contains a detailed listing of the regulation, which contains the mechanism requirements, as well as the approved mechanisms and the way that CMS will accept applications for that. But to that end, National Decision Support Company, and through our delivery of ACR Select, is obviously a fully qualified mechanism.
Fantastic. Thank you, Bob. Actually, I'm not going to let you catch your breath because I do have another question for you. Could you briefly describe how RScan integrates with existing information systems?
Yeah, happily. So as everybody's aware, the RScan program can be obviously delivered through a website version where providers can interact with the criteria and the program and the website. But since the RScan program is founded on the NDSC CDSM, and the NDSC CDSM is also, and that I apologize for the acronym salad, but our decision support mechanism, Care Select, is integrated into electronic medical record applications. And when providers are interacting with the AUC, obviously we are recording in our mechanism those transactions. We've developed an integration to the RScan registry such that sites that have an integrated mechanism have adopted the Care Select or ACR Select platform and are interacting with the AUC can actually now, using an automated registry submission, run their pre and post assessments simply based on the provider's interaction with the AUC and automate the process. And so as a result, not only can you run a compliance program with a decision support mechanism, you can also apply Choosing Wisely guidelines and other guidelines, even covering other service lines, and then automate your participation in programs such as RScan.
Great. We'll give you a chance to catch your breath now, Bob. All right. So the next one is for Dr. Law. What is CMS doing to ensure referring physicians are educated and prepared? And of course, RScan is a wonderful example of that.
I think I would have to leave this. I would have to ask Dr. Silva to weigh on it, but I'm sure there's a lot of educational material on the CMS website. Zeke, would you be able to
absolutely, and I'll ask for Bob's input as well. But yeah, I will add a few points. One is the educational activities from CMS. I mean, they've got information on their website itself.
Mm-hmm.
You have to remember, RSCAN was part of a Transforming Clinical Practice initiative. So there was actually funding specific to entities such as the ACR for RSCAN. But it's also my understanding that there's information out there, or funding out there for education regarding the quality payment program in general. And I would think secondarily for these types of AUC programs, et cetera. Then I would just defer to Bob, and I'm sure I would also say that the ACR itself, we put significant resources into not only educating our own members and radiology professionals, but we're putting information on our website and availability for referring physicians and patients alike. Bob?
Yeah, so clearly as a mechanism producer, and I would suggest that anybody that's involved in this program would have a dog in the hunt with respect to educating ordering providers and the marketplace on why both AUC interactions matter, as well as how best to meet the compliance regulations. So we've obviously been a very active participant in the educational process. Together with the ACR, have actually authored steps forward educational modules together with the AMA and listed those on the AMA website. And, both continue to collaborate with the radiology community, the American College of Radiology, and as well the overall marketplace directly on educational initiatives. But, I think with respect to CMS's obligation with respect to education, I think this falls into the bucket of, like most regulations, they are making the marketplace aware of their requirements and to a degree rely upon industry and market implementations to drive education and awareness. At least that's the case for the program. Yeah.
Thank you. Got another question. We'll start with Dr. Silva. Are hospital-based imaging facilities and physician practices both required to prove CDS consultation for their Medicare patients? That is from Vicki Parikh again.
Yeah, it's an important question. So the program applies to both the technical component and the professional component of imaging services. Now, in an office setting where a site might be billing globally, or one claim for both of those, then that would be part of the single claim. But if there's a circumstance, for example, in the hospital outpatient setting, where the hospital is billing for the technical component, the physician's billing for the professional component, then those would be both separate billing processes, and both of those would be responsible. Now, the astute billers in the audience will know that the Medicare physician fee schedule is paid from Part B, and that's a separate claims-based process than, say, hospital outpatients, which is part of what's called the Hospital Outpatient Prospective Payment System, which has a different claims-based process through a separate claims form. And this is one of the important responsibilities of CMS, and I think it's one of the important responsibilities for those on this call is, educating not just physicians, but also educating providers such as hospitals or physician offices that may not be run by the practice itself, on how those claims-based processes will be performed. And maybe ask if Bob wants to add some comments to that.
Sorry, Zeke. Would you mind repeating the question?
So the question, Bob, and I think it's an important one, is does this program apply to both the professional and the technical side of the billing process?
Mm-hmm. Yeah, absolutely, and it does, obviously. And, there are multiple ways to convey the information from the order to the furnishing side, in particular, if the order is in a different location and care setting from where the exam is furnished, and possibly even from where the interpretation or professional component is applied. And so as a result, industry has gotten together and identified means to convey the information across these care settings. Both, we've got a draft in terms of what are the, the data elements in terms of the HCPCS and G codes that might need to be conveyed across these settings, but also provisions to convey that unique consultation identifier or decision support number, which is actually generated when the ordering provider actually interacts with the mechanism. And that happens either invisibly or visibly. And when the provider is, for example, interacting in a website version, which is no fee, they'll actually get a decision support number right there on their screen and a PDF document that can actually be emailed or entered into their EMR systems to ensure that that data conveys with the order. And obviously the means of the conveyance of that information across the care setting to both the furnishing and the professional side needs to accommodate the method that, obviously that site is used to actually interpret that exam. And so as a result, I think one of the most important aspects of this program now, as we move from, enabling consultations to actually now linking this program to payment, obviously on the furnishing side, we've got to start to work together with the billing companies and the revenue cycle automation programs to ensure that we're actually getting this information from the order all the way down to both the furnish and the professional service. But absolutely, both claims require consultation data. And one way to convey that information across the care setting that's very simple is simply to convey that unique consultation identifier. And then all CDSMs have the capability to essentially reverse look up that decision support number to actually pull down the information. So minimally, if all you've got is that UCI or that DSN, you'll be able to actually get the consultation data associated with that service.
All right, thank you. You may have touched on this one briefly during the answer to this last question, but this one is from Ken Wang as well. The speakers have touched briefly on G codes and code modifiers, indicating that these are used in part to indicate hardship exemptions. I'm curious what specific G codes and code modifiers we need to know about during the voluntary reporting period, or are these still in flux? We'll start with Dr. Silver.
Yeah, it's an important question. So during the voluntary period, which just as a reminder, that started in July of this year, and it's going through the end of next year, through the end of 2019. In that scenario, the only requirement from the modifier side is that QQ, Q as in Queen. And that would be, so for example, if it were a CT of the chest, that specific CPT code would just have the QQ modifier appended to it. Now the question becomes, what happens when the G codes and the modifiers become more specific and required, which we expect will be at the 2020 timeframe. In that, recall that they actually put this into place. They made this proposal in past rulemaking processes, and the G codes, and I'm going to ask Bob to make sure I'm correct in these statements shortly, but the G codes are CDSM specific. So if you're using a certain qualified clinical decision support mechanism, that G code would indicate that's the mechanism that you use. The modifier would indicate, one, if the claim was adherent to the AUC recommendations, non-adherent, or non-applicable. And getting back to the question regarding the hardships, I'm not aware that we've received from CMS the specific guidance on what that modifier might be, but as soon as we receive it, and again, I'll just remind the audience that this is a proposed rule cycle, so we're talking about rules that very likely will go into effect, but because it's a proposed rule as we speak, there's a theoretical possibility they won't be finalized or that they could be evolved, which puts sort of the onus back on the ACR and to Bob and the National Decision Support Company to, as soon as that final rule drops on November 1st and those rules become more apparent, more understood, it's going to be incumbent on us to get that communication out as soon as possible. Bob, any perspectives?
Thanks, Zeke. So number one, yes, I confirm your analysis. Each mechanism gets a G code. Each CPT will be modified with at least one of four modifiers, which would be adhere, not applicable, i.e. there was an AUC found, or some exclusion. The degree to which we want or exclusion specificity will be reported is obviously unknown. I would add that CMS provides guidance to the sites in the form of transmittals, which happen outside of the rulemaking and the regulatory process. And so, for example, we received recently the transmittal that defined how and put the providers and the MACs on notice that the QQ modifier was going to be accepted, during the voluntary period. And we would expect that similarly, a transmittal will be issued that will both assign G codes to mechanisms as well, define the CPTs and the modifiers required and which services will be accepted in a transmittal following this rulemaking cycle as well.
Okay, looks like we're going to have time for one more question here. How does the ACR recommend small physician-owned imaging practices educate their referring physicians? We'll start with Dr. Silva.
Right, so and that's the question when the program sort of went into effect was, how do we make this program accessible and beneficial to practices of all size? And I'd say secondarily, put the program into place in a way that doesn't give any sort of a competitive advantage to a large site that may have better resources to do it. So it's an absolutely fair question. Is how does a smaller practice or single physician-owned office put this into place? I think a lot of what Dr. Lal described would apply here in regards to those respective referring physicians. I think the fact that there is not just a requirement, but there are 3 separate free web-based tools, including the ACR and Care Select, available to those practices. I think the interface is available. And then I think from there, it's just a matter of interfacing with the vendors, interacting with the clinical decision support mechanisms, such as Bob's entity itself. Receiving that guidance, I think, are important steps. And I defer to Bob on this one again for additional input, please.
Yeah, no problem, Zeke. I think basically at this point in time, my recommendation to any of these small practices seeking to both engage, educate, and drive value would be to start an RScan program up. You're immediately exposed to interaction with a CDSM through the interactions provided through the RScan user interface. You get actionable data. You get all kinds of educational and MOC type credits on both sides of the fence. And that it is a great way for sites to put a value proposition now around engaging with the AUC program and helping convey the value of that collaboration. And through those tools, when the regulation comes online, you're going to be in a much stronger position to support the consultation process and to drive value through your imaging services and access to the AUC on behalf of your referrers.
Fantastic. As I said, that was our last question for tonight. Thank you, Mr. Andrews, Mr. Cook, and Drs. Lal and Silva. And thank you, everyone out there, for attending tonight's webinar. Once you leave the webinar, you will receive a survey on the presentation. We would appreciate it if you would complete that and provide your feedback. You'll also receive a follow-up email within a few days with the link to view a recording of tonight's webinar. That recording will also be posted to the ACR's website, acr.org. Again, thank you for joining us. Have a great night, everybody.